Hello everybody, and welcome to this session on recent advances in inborn errors of immunity. Martha and I are very happy to be chairing this session, which we hope you will find interesting and informative and will provoke some lively discussion, even though, of course, we're having to do this virtually rather than for real. This is a very interesting and exciting topic and illustrates just how quickly our field is moving and how much there is that is new and exciting and of great interest. So, thank you for joining us.
Hi, I'm Puel. I'm working at Imaging Institute, Necker Hospital in Paris. And I would like to thank the organizer for the opportunity to present the most recent advances in a hyper-IgE field, which have further deciphered this complex disorder. So, hyper-IgE syndrome, or Job syndrome, was first described in 1966 by Davis and colleagues in two young girls who presented recurrent cold staphylococcal abscesses, respiratory infection, and eczema. And this syndrome was named Job syndrome in reference to the boy. In 1971, a young girl with Job syndrome was reported with extremely high IgE levels. And in 1972, Becky Buckley and her team reported two young boys with recurrent infection, severe eczema, extremely high levels of serum IgE, and subdevelopmental features. So for almost 10 years, Job syndrome and the syndrome with recurrent infection and high levels of IgE were considered to be two different disorders. However, it's in the early 80s, they were to be considered as being the same entity and were named hyper-IgE syndrome. So it's a complex disorder, and in the following years following its description, many efforts have been made first to evaluate patient clinical phenotypes using a sort of scoring system such as the NIH score to define its modes of inheritance, as well as to identify the underlying genetic defects. So between 1999 and 2004, it was shown to have two modes of inheritance. The autosomal dominant mode of inheritance, which corresponds to the classical hyper-IgE syndrome and which is characterized by recurrent infections, extremely high levels of IgE in the serum, and some developmental features. The autosomal recessive form of inheritance was reported in 2004 in patients with also high levels of IgE, but no developmental disorders, but with viral and fungal infection. So soon after this, various inborn errors of immunity have been reported and were considered to be genetic causes for the disease in those patients displaying high levels of IgE. However, some of them are now categorized in other groups, such as autosomal recessive DOCK8 deficiency, which is now considered as being responsible for combined immunodeficiency, or TYK2 deficiency, which is an inborn error of immunity, mainly causing mycobacterial and viral disease in the context of normal IgE levels. So the 2019 IEIs classification has now altogether there are 10 genes considered as being cause of hyper-IgE, either with an autosomal dominant or recessive mode of inheritance. So can these 10 genes be considered as hyper-IgE disease-causing per se genes? It's still under debate. For example, CARD11 deficiency or PGM3 deficiency could be considered as combined immunodisorder causing gene. So in the next 15 minutes or so, I'm going to summarize the most recent research which has been done in the hyper-IgE syndrome, and with the identification of novel inborn errors of immunity, which phenocopy most, if not all, features seen in STAT3 deficient patients. So very briefly, up to now, over 300 patients with hyper-IgE syndrome caused by STAT3 mutation has been described, and over 140 mutation, heterozygous, loss of function, and dominant mutation has been described in STAT3. So very briefly, the patient is characterized by very early onset eczema, as well as very early onset bacterial skin and pulmonary infection, and chronic mucocutaneous candidiasis. So the patient usually display a poor inflammatory sign, and they usually have extremely high levels of serum IgE, which can decrease with age, associated with eosinophilia. The laboratory findings usually show overall normal leukocyte counts. However, this patient usually display low memory B cells, and some T cell subpopulation are affected, and in particular, they display low proportion of Th17 cells. And finally, they also display extra hematopoietic features with connective tissue, skeletal, and vascular abnormalities. So the complexity of STAT3 signaling downstream of many receptors, as well as its expression in many tissue, made it very difficult to understand the mechanisms which were underlying the disease. However, the progressive description of inborn errors affecting either the cytokine or the receptor signaling through STAT3 have progressively clarified the hyper IgE syndrome phenotype. So the first inborn error I'm going to talk about has been reported in 2018 by the team of Bodo Krimbacher and by our team in a total of 19 patients born to 10 families with the hallmarks of patients with STAT3 deficiency. So they were all or most born to consanguineous families, suggestive of an autosomal recessive mode of inheritance. We didn't find any rare variants in the gene known to be associated with high IgE levels. And using next generation sequencing, altogether, we identified five nonsense homozygous mutation in the gene ZNF341. So at that time, nothing was known about ZNF341, except that it has 12 zinc finger domain, as well as 2 predicted nuclear localization sequence, suggesting that it could be a transcription factor. So very briefly, by overexpression, we showed that the wild-type protein was mainly expressed in the nucleus. None of the mutants expressed a normal molecular weight protein. By ChIP-seq analysis, we could see that ZNF341 was binding to many DNA regions within the genome, with the strongest binding site within the STAT3 promoter. We could define the region it could bind to, and by electromobility shift assay, using a probe containing these 2 motifs, we could see that the wild-type protein was indeed binding to this probe, whereas the mutant protein barely bind to this probe. So we then try to look at, to better decipher the function of ZNF341 in the patient leukocyte subpopulation. And as illustrated here, in patient-naive CD40 cell, we could see that the patient with ZNF341 deficiency expressed lower levels of STAT3, both at the mRNA and protein level. And upon stimulation of these cells with IL-6, we could see a strong reduction of STAT3 phosphorylation. So altogether, this work showed that ZNF341 is a transcription factor that regulates both STAT3 expression and function. In 2017, Schwerd and colleagues reported a patient with biallelic loss of function mutation of IL-6ST encoding GP130. So whereas complete GP130 deficiency cause an extremely severe syndrome with characteristic skeletal abnormalities and often associated with early death, Schwerd and colleagues report 1 patient with a homozygous mutation, missense mutation in GP130. So GP130 is a signaling receptor which is used by all cytokines from the IL-6 family, such as IL-6, IL-11, IL-27, IL-31, oncostatin M, leukemia inhibitory factor, etc. So the patient display most of the infectious and immunological features of patient with STAT3 deficiency, except that he did not suffer from chronic mucocutaneous candidiasis, and he had a normal proportion of Th17 cells ex vivo. As illustrated here, he was suffering from severe craniosynostosis and also progressive scoliosis. Both in overexpression and in patient cells, the author could show that the patient display extremely impaired signaling downstream of IL-6 and IL-11. The signaling downstream of IL-27 and oncostatin M was also affected, whereas the response to LIF was largely intact. So more recently, the same team reported also another patient with a homozygous missense mutation of IL-6ST, but this patient displayed only craniosynostosis and retained deciduosity. By overexpression, they could show that this missense mutation impaired IL-11 signaling, whereas IL-6, IL-27, oncostatin M, and LIF signaling were normal. So suggesting that the impaired IL-11 signaling was responsible for the patient's phenotype. And this was actually in accordance with a work reported in 2011 about patients with complete IL-11 receptor deficiency displaying severe craniosynostosis, delayed tooth eruption, and supernumerary teeth, strongly suggesting that IL-11 is essential for normal development of craniofacial bones and teeth. And therefore, the combined effect of IL-11 signaling together with that of LIF signaling is, which is crucial for the normal skeletal and bone development, probably explain many of the extra-hematopoietic features seen in STAT3 deficient patients. So more recently, we reported 12 patients from 8 kindred with many of the immunological and infectious features of patients with STAT3 deficiency, except that they display mild chronic mucocutaneous candidiasis and skin abscesses, and they had normal proportion of Th17 cells ex vivo, but low frequency in vitro. Using next generation sequencing, we identified in those patients 7 nonsense of frameshift mutation, shown in red here, of IL-6ST, heterozygous mutation. So these mutations were first predicted to be expressed at the cell surface because they were locating downstream of the transmembrane domain. However, they were losing the recycling motif, shown in yellow, and which is located downstream of the mutation. And they were also predicted to lose the 4 STAT3 binding sites, which are also expressed downstream of the mutation. And indeed, in an overexpression system, in X cells like in GP130, but overexpressing the wild type and the various mutant, we could show that this allele impaired the response to IL-6, IL-11, LIF, oncostatin M, and to a lesser extent to IL-27. And we also showed that they were dominant negative for most of these cytokines. Using patient fibroblasts, we could see either by flow or by Western blot that indeed the patient displayed a stronger expression of GP130 at the cell surface. And we showed that this mutation impaired the signaling downstream of IL-6 and to some extent also downstream of IL-11, whereas LIF signaling and oncostatin M signaling was normal. So last, Spencer and colleagues reporting in 2019 2 patients with either homozygous or compound heterozygous of IL-6 receptor. When we look at the phenotype of this patient displays most of the immunological and infectious features seen in STAT3 patient. For example, they displayed extremely severe eczema, recurrent skin and lung bacterial infection with impaired acute phase responses. They had high levels of IgE and with eosinophilia, normal TB and NK cells, but reduced memory B cells. However, they did not present any chronic mucocutaneous candidiasis, and the proportion of Th17 cells were normal ex vivo, however, with a poor differentiation in vitro. When we look at STAT3 or STAT1 phosphorylation in CD40 cells upon IL-6 stimulation, we could see that the patients show a complete abolished response to IL-6, both by flow cytometry or by Western blot. So remarkably, 12 years ago, we reported a patient with recurrent staphylococcal cellulitis and abscesses with no increase of CRP concentration during the infection. So this patient had extremely high levels of autoantibodies against IL-6, which were neutralizing to IL-6. So this further suggests that the impaired IL-6 signaling is responsible for many of the infectious and inflammatory features seen in STAT3 deficient patients. So in conclusion, the last 3 years have witnessed the identification of novel inborn errors of immunity, which have progressively helped to further decipher the molecular and the cellular mechanisms underlying hyper-IgE features in STAT3 deficient patients. So many questions remain, however. But patient with ZNS341 deficiency, phenocopy, patient with STAT3 deficiency. Patients with GP130 deficiency display most of the features seen in STAT3 deficient patients, but they do not suffer from chronic mucocutaneous candidiasis and show normal proportion of Th17 cells ex vivo. Finally, patients with IL-6 receptor deficiency recapitulate many of the STAT3 features, infectious and immunological complications, except that this patient, at least the two reported, did not suffer from chronic mucocutaneous candidiasis and had normal proportion of Th17 cells ex vivo, suggesting a redundant role for IL-6 signaling to protect against chronic mucocutaneous candidiasis and in the development of Th17 cells. And finally, most of the STAT3 extrahemopoietic features were seen in patients with IL-11 receptor or LIF receptor signaling, suggesting that the impaired IL-11 and LIF signaling in patients with STAT3 deficiency probably explain many of these extrahemopoietic features. So I would like to thank the patient and the family who have participated to our studies. Within the lab, I would like to thank Viviane Béziat, Bertrand Boisson, and Jean-Laurent Casanova. And I would like to thank all the collaborators worldwide who have strongly helped us to report this work. Thank you for your attention.
Well, thank you for the kind invitation to talk today about the recent advances we've experienced in gene therapy for primary immune deficiency. So my name is Claire Booth, and I'm a pediatric immunologist and gene therapist at Great Ormond Street Hospital in London. So I'm not going to concentrate on published studies here, but I want to give you an idea of the current trials and where the field is heading. So questions can be submitted during the talk via the Q&A function in the top right corner of the screen, and these questions will be addressed in the live Q&A section at the end of the session. These are my disclosures. So the premise of gene therapy is really quite simple. We take the patient's hematopoietic stem cells, usually sourced from mobilized peripheral blood. We select the CD34 positive population, transduce those cells with a lentiviral vector containing the transgene of interest. Those cells then integrate a copy of the corrective transgene. The cells are returned to the patient, usually after some form of myeloreductive or myeloablative conditioning, where they engraft, express a functional protein, and the child develops a working immune system. So advantages of gene therapy are that we can avoid any alloreactivity. There's no risk of graft versus host disease because we're using the patient's own cells. And we can usually use reduced conditioning compared to stem cell transplant. Now, the history of clinical gene therapy for PIDs hasn't been straightforward, as you can see from the timeline here with ups and downs. But from the nadir in 2003, when several patients across gamma-retroviral trials developed leukemia and myelodysplasia, the field has got back on track with the advent of safer lentiviral vectors, and indeed gene therapy and now gene editing is being applied to an expanding range of immune deficiencies. There have been a number of improvements made across the whole process of gene therapy, which I think have really impacted positively on the success of the technology. So we can now effectively mobilize and harvest large numbers of peripheral blood stem cells using GCSF and pluric support protocols, and the greater of number of cells correlates with improved outcomes. We've developed better transduction protocols, keeping cells ex vivo for shorter periods of time, and using molecules called transduction enhancers to improve efficiency, allowing us to use less vector and therefore cut the cost of the procedure and make our vector go a longer way. So cryopreserved products and targeted conditioning regimes mean that we can minimize chemotherapy-related toxicity whilst maximizing engraftment. And we've also now seen a huge increase in the number of commercial partners in this area, which can help to support more rapid translation of promising studies and eventually should help more patients be treated. Of course, cost remains an issue, but we have really seen transformative results for patients treated in recent clinical trials. What we need now is more data and a greater understanding to work out who will benefit most from gene therapy procedures and why. So I wanted to just briefly touch on haploidentical transplants, as this is an area where outcomes have really improved with the adoption of new technologies. So I don't think we should be thinking of these as competitor strategies. We're all looking to provide patients with the best possible chance of cure with the least toxicity, but we must be aware of the current results so that we can counsel patients appropriately as to their treatment options. So historically, results from haplotransplants were poor, with patients dying from GVHD, infection, and rejection. But results with TCR alpha beta depleted grafts are good. Mary Slatter published results a couple of years ago from cohorts of patients with primary immune deficiencies, and overall survival was up to 90% in certain centres. So we need to be aware of these advances to understand what's the best option for individual patients. And as centres have increasing experience with these protocols, we're beginning to understand that some patients may benefit more from gene therapy than others, and patient selection will be an important discussion. So many factors need to be taken into account. For example, in this graph taken from Mary's paper on outcome following haplo, clearly shows that patients don't do well if they have infection. So perhaps these patients would be better candidates for gene therapy. Similarly, perhaps older patients with multiple comorbidities would enjoy better outcomes with gene therapy than a mismatched transplant. Unfortunately, we don't have these answers yet, but more and more data is being generated to guide us with these kinds of decisions. I'm going to touch on cryopreservation of products as well, because I think this has been a real game changer for the field. And so by cryopreserving transfused patient cells, we can ensure the product is of optimal quality to support a successful outcome. We have flexibility over timings of the procedure to allow for example, targeted chemotherapy to be achieved. And hopefully we can improve accessibility to products as the product can travel to the patient rather than the patient having to relocate to a dedicated center. And cryopreservation has allowed the development of centralized manufacture processes. The idea being the patient can stay in their local center, undergo apheresis there. This is then shipped to a central manufacturing facility where cells are transduced, cryopreserved and QC tested, and then released back to the local center for infusion into the patient. So this will hopefully increase availability of gene therapy products, and commercial companies have really driven this process. We're moving to recent advances in gene therapy for SCID. So XSCID is a great exemplar of how the field's evolved, starting with the gamma-retroviral vectors in the late 1990s. So this table summarizes the changes we've made to XSCID protocols along the way, based on what we've learned from our experiences. So we've changed vector design to improve safety, we've optimized transgene expression, and introduced conditioning, which has led to improved results. So in the first gamma-retroviral trial, where no conditioning was used, the vast majority of patients recovered functional T cells, less than half had functional B cells, and 6 out of 20 developed leukemia as a result of the gene therapy. So the viral LTR, or long-term repeat elements, these strong promoter enhanced elements in the vector being used to drive transgene expression, were also activating oncogenes and leading to leukemia, termed insertional mutagenesis. So the vector design was then changed to remove these elements, and a mammalian promoter was added to drive the IL-2 receptor gene. So this protocol still didn't use any chemotherapy, and patients recovered T-cell immunity but failed to recover humoral immunity, apart from one patient who received low-dose busulfan to promote engraftment of gene-corrected cells. So the current trial, which is open and recruiting in line 3 here, has evolved further to use a lentiviral vector, which has an improved safety profile over gamma-retroviral vectors. The product is cryopreserved, and low-dose busulfan is included to secure engraftment. So early results are promising, and those patients far enough out have stopped immunoglobulin and responded to vaccines. And importantly, there have been no safety concerns since the gamma-retroviral trials. And this trial is now open in Boston, UCLA, London, and Atlanta. So from the patients we've treated so far on this lenti trial, we're already seeing pretty fast T-cell recovery. Looking at the CD3 counts, by 3 months, we're already reaching 1,000, and they continue to improve after that. We're also seeing stable gene marking in the lymphoid and myeloid compartments with the addition of chemotherapy, and this correlates with B-cell functional recovery and the ability to come off immunoglobulin and respond to vaccines. Another lentiviral trial for XKID is underway at St. Jude's Hospital, UCSF in Seattle, using a slightly different vector with an insulator element. And these investigators have published preliminary results on 8 patients who've been treated, but more are being treated already. And again, they're using low-dose busulfan to secure engraftment. They've demonstrated engraftment of gene-marked cells with T-cell recovery and B-cell engraftment, allowing again patients to come off immunoglobulin. One patient in this series required a boost. Moving on to ADA-SCID, a lentiviral approach has also been developed for this condition, and I've included this summary slide because I think it's really an excellent example of parallel clinical trials generating a huge amount of data for a large cohort of patients with ultra-rare disease. So between London and UCLA, we've treated 59 patients with 100% survival and 97% efficacy. So 97% of patients have been able to stop enzyme replacement therapy, have good immune recovery, sustained ADA production, and remain detoxified. And this data is licensed to Orchard, who are progressing the program towards market. These are slides courtesy of Don Cohn in UCLA on the US arm of the trial, where he compared gene therapy treated patients with historical transplant controls, either with or without a matched related donor. And what we can see is sustained engraftment through to 2 years with stable vector marking in both granulocytes and PBMCs. In terms of overall survival at 2 years, at 12 months post-treatment, overall survival was 100% in the gene therapy treated group. And the gene therapy treated group is always in the blue line, the light blue line. And that's compared with 92% of patients receiving transplant. And at 2 years, overall survival remained 100% in the gene therapy group, compared with 88% of patients receiving transplant. Looking at event-free survival over that 2-year period, event-free survival was 97% in the gene therapy group, and that was statistically significantly longer for the transplant group, where 56% of all patients receiving transplant required a further intervention. Looking at metabolic detoxification and ADA activity in the gene therapy group, ADA enzyme activity increased from baseline over 2 months post-treatment and remained at levels seen in healthy children. In the transplant group, the ADA enzyme activity increased at a lower rate over the first 6 months and remained at lower levels, as you can see here. In terms of DAXP and the metabolite levels, all subjects across both groups, the levels came down to normal limits by month 12, but it was faster in the gene therapy group than the transplant group. Moving on to immune reconstitution and T-cell recovery. So both CD3 and CD4 compartments at 24 months, the median CD3 count was over 3.5 times higher than at baseline level and higher than in the transplant recipients. We see a similar picture in the CD4 compartment with over 4 times improvement over baseline and 3 times higher in the gene therapy treated group than in the transplant groups. Looking at naive T cells, again, it's a very similar picture The median naive T cell count reached over 4 times baseline level at 18 months, and this was sustained out to 2 years. And again, this was significantly higher in the gene therapy group than in the transplant. And finally, looking at B cell counts and humoral recovery. So again, B cell counts were higher in the gene therapy treated group than in the transplant group, meaning that more patients were able to come off immunoglobulin replacement in the gene therapy treated group. And I think that this slide really shows what a fantastic position we're in. So we've now got several gene therapy-based options for patients with SCID. We have a licensed product for ADA SCID. We're tackling more complex forms of SCID2, like Artemis and RHOG1, and gene editing is on the cusp of entering the clinic. And of course, there's preclinical work going on by several groups for other forms of SCID as well. So one trial that's also open and currently recruiting is for leukocyte adhesion deficiency, type 1. This is sponsored by Rocket Pharma and is a collaboration between UCLA in Madrid and Whitman Street in London. So Don Cohn has already presented the results of these first patients treated a couple of days ago at this meeting. But I just want to highlight here that 2 patients have been treated now with 12 months and 4 months of follow-up. The safety profile of the drug product appears favorable, and in terms of preliminary efficacy, both patients have seen CD18 expression of around 30%, and this correlates with improvement of clinical manifestations. So what's coming next? I already mentioned that a clinical trial for lentiviral gene therapy in RHOG1 is about to open in the Netherlands, in Leiden, including patients who have no matched donor available for transplant. And they're going to be using a busulfan fludarabine conditioning regime and aim to enroll 10 patients across European sites, so starting in Leiden and then moving to London as well. So this has now been approved in the Netherlands by the competent authority, and wider regulatory approval is in process. So CGD is characterized by recurrent and often life-threatening infections and hyperinflammation, and it's caused by defects in the phagocytic NADPH oxidase responsible for killing pathogens. So a defect in any of the 6 components of the NADPH oxidase system can lead to a CGD phenotype. And results from a gene therapy trial for X-linked CGD caused by GP91 defects were recently published in Nature Medicine. But we're now targeting the autosomal recessive form of CGD caused by mutations in the P47 FOX gene. And using this lentiviral vector with the transgene driven by a chimeric promoter formed of myeloid-specific transcription factors to improve myeloid-specific expression, the murine model was successfully corrected, demonstrating recovery of neutrophil function as shown here by DHR results on HSC-derived granulocytes. And you can see the DHR improves with increased copy number. And then mice receiving gene-corrected hematopoietic progenitors were challenged with salmonella, which is a leading cause of sepsis in CGD patients. And these mice showed significantly reduced bacterial counts in the spleen compared with untreated mice, again demonstrating functional neutrophil recovery. And this is now moving towards a clinical trial in the US and the UK, planning to open early next year. So in some PIDs, the T cell compartment is predominantly affected with clinical manifestations stemming from T cell dysfunction. And in these diseases, it may be possible that an autologous gene-modified T cell approach could offer clinical benefit with reduced toxicity. And proof of concept has been published now for a number of these conditions, including IPEX, CD40 ligand deficiency, and forms of familial HLH. And of course, CAR T cells also demonstrate the feasibility of this strategy. So one disease that we are taking to clinical trial in the next couple of years is X-linked lymphoproliferative disease, or XLP, caused by mutations in the SAP gene. And patients suffer from a range of clinical symptoms, including HLH, lymphoma, infections, and immune dysregulation. But these are caused primarily by abnormal T cell function. So we generated and published some very promising data in murine models and patient cells showing recovery of humoral and cellular immune defects. So in terms of humoral defects in the mouse model, we've demonstrated restoration of germinal center formation following antigen challenge, and also T follicular helper cell function and T cell dependent antibody responses in patient cells in vitro. We've also demonstrated correction of cytotoxic defects, so CTLs were generated from healthy donors and XLP patient PBMCs, and patient cells were then transduced with our lentiviral vector and injected intravenously into NSG mice with established luciferase expressing LCL tumors, and then we monitored tumor burden over 10 days. So tumor regression in animals receiving patient-corrected CTLs was comparable to that from receiving healthy donors. So you can see on the left-hand panel, those are animals that receive healthy donor CTLs. On the right-hand panel, the top panel is XLP patients, uncorrected cells, and then patient-corrected cells, and again, you see complete resolution of the tumour. So we're planning a clinical trial of this therapy to start in the next 2 years for patients lacking a matched immune donor for transplant, and we plan to use some form of lymphodepletion to improve engraftment. So obviously gene editing is a very hot topic at the moment. We now have a number of platforms available to undertake targeted genetic correction, zinc finger nucleases, TALENs, and the CRISPR-Cas system. And correcting the gene in situ in its native locus should allow for expression of that gene from native regulatory elements, ensuring a more physiological expression profile. And this is going to be particularly important for conditions where aberrant expression or partial expression can be harmful. So all of these platforms use the same premise. They have site-specific sequences targeting a specific locus, and these are combined with endonucleases capable of initiating a double-stranded break in the DNA. So this is then repaired by either non-homologous end joining, which happens more frequently but is error-prone and good for knocking out genes, or through homologous recombination or homology-directed repair, which allows for faithful correction if a suitable donor template is provided. And we're now seeing evidence that this technology can correct patient cells and restore function. So XSCID, again, was a target for gene editing, particularly as corrected cells show a strong survival advantage. So Pietro Genovese and Luigi Nardini's lab in Milan demonstrated that less than 10% gene correction could correct the disease phenotype using murine models because of this strong advantage. And 10% is an achievable level of efficiency, although of course we'd like higher. So using one of the earlier platforms, zinc finger nucleases, he targeted insertion of a corrected AAV6 or adeno-associated virus donor after the first exon of the IL-2 receptor gene, and successfully also targeted the locus in hematopoietic stem cells from XSCID patients, demonstrating the therapeutic potential of this approach. And previously, editing of HSCs was extremely low efficiency. And once engrafted into xenograft murine models, these gene-corrected patient cells developed functional lymphoid cells with the capacity to proliferate upon antigenic stimulation, as shown here, and to secrete interferon gamma following LCMV challenge. Matt Portis's group then used the CRISPR-Cas system to target the same locus and correct the disease phenotype, assessing particularly which stem cell populations could be edited to give the best correction. So using a CRISPR-Cas AAV6-based strategy targeting integration of AAV6 delivered cDNA to the endogenous start codon, they achieved up to 20% targeted integration in long-term hematopoietic stem cell progenitors. They also showed high levels of targeting, a median of 45% in CD34 cells from 6 XSCID patients, and demonstrated rescue of lymphoid defects in patient-derived stem cells, both in vitro and in vivo. And here you can see the results from corrected stem cells of patient 2 engrafted into NSG mice and then subsequent recovery of lymphoid lineages as shown in the right-hand bar chart. There were no abnormalities of hematopoiesis observed or evidence of off-target effects. And this strategy is moving towards clinical trial at Stanford. In London, Alessia Cavazza and Adrian Thrasher's group have been working on developing strategies for Wisker-Aldrich syndrome using the CRISPR-Cas system, and this has been recently published. So Wisker-Aldrich syndrome affects both the lymphoid and the myeloid compartments and is characterized by microthrombocytopenia, eczema, autoimmune complications, and cytoskeletal defects. And using CRISPR guide mRNA targeting the first exon of the gene and several different corrected AAV6 donor vectors containing codon-optimized Wiskott cDNA, followed by either a poly-A signal or the 3' UTR, patient stem cells were edited and then differentiated in vitro into either macrophages or platelets. And they compared these approaches to the lentiviral vector with 1.6 kb promoter, which is currently in clinical trial. And the construct containing the poly-A signal, WPA, showed the highest efficiency with targeted integration amongst positive cells. And as you can see on the bottom panel, the expression profile was close to wild-type cells. Here, the WPA construct is shown in red, achieving MFIs comparable to wild-type stem cells and macrophages. And in terms of functional readouts, and I haven't shown this data here, proteasome formation was recovered in edited macrophages, and platelet granularity also improved towards wild-type levels. They also corrected patient T cells using the same constructs with IL-2 secretion and proliferation as a functional readout. And again, they saw high levels of targeted integration, about 50% across positive cells, and the expression profile was most similar to wild type, again with the WPA construct here in red when compared to other constructs. and this correlated with improved IL-2 secretion. So we can certainly achieve clinically relevant correction levels at small scale, and this supports translation through to a trial. So although these are promising strategies and may be very applicable to conditions where physiological expression is beneficial, the path to clinic is currently limited by the efficiency of correction. So in situations where there's a powerful selective advantage, this may be sufficient, but many groups are working on improving correction to clinically relevant levels. These are some of the challenges I've listed here. I think the main ones really relate to efficiency at the moment, but I think that it is possible that knock-in technologies will be in clinical trial for immune deficiencies in the next 2 to 3 years, and I know many groups around the world are working towards that timeline. So, I mean, all of the work I've shown here is the result of huge collaborations at many centres across the world. These are just some of the people who've been involved, and I'd just like to thank all of them, and I'd like to thank you for your attention.
For listening to this new Inborn error of immunity session. We would like to thank Anne, Claire, and Cant for the excellent presentation. We really enjoyed it. The best way to start Saturday morning, I would say, together with your coffee. And we had really lots of questions. That's exactly together with so it's not only my interest, but it's the interest of the audience. And I would like to start asking a couple of questions to Cant about lots of interest came about your HEM1 deficiency. And one question came from Kimberly about if M1 patients will lose, based on their phenotype, their B cells over time. Can you comment on that, Cant?
Thank you, Marta. Thank you, Kimberly, and good morning to everybody. So it is a little bit hard to answer that question because in the patients, as you know, you have somewhat distinct severities of the disease, which is not atypical for especially these immune dysregulation syndromes. So for those of you who've seen the publication, we actually studied 2 patients, and the disease severity was actually different in these 2 siblings, despite obviously carrying the same genetic defect. And now you can, of course, speculate how much there is environmental or other modifying factors that modify severity of disease. We did have the impression that there was a reduction of B cells over time, but I really don't feel certain to make a strong comment here, given only sort of a single family with 2 affected individuals. In the mice, obviously, the problem is somewhat different. The mice are terribly sick. Arguably, they're even more sick than the patients. And so, we cannot trace them for too long because they just don't live very long, and you have to sacrifice them at a relatively young age. So whilst we have done the single-cell sequencing experiments, one could not let them age above sort of 3 or so months.
Mm. And as you are talking on the mice, there was a question from Sandra Amman. Did you do an LCMV infection in the mice and check if they do develop HLH symptoms?
No, we didn't, but I think it's a very interesting thing to do. Mm-hmm. And if Sandra is interested, I would be very happy to talk to her, privately.
The right place to
we could do this sort of in conjunction.
Yeah. And always on M1 deficiency, what about the thrombocytes? And can you comment on that?
Yes, excellent question. So the thrombocytes were slightly reduced, but not nearly as dramatic as is usual for Wiskott-Aldrich syndrome. So with typical counts about 100,000 or so, as we also depicted in the paper. And they also didn't have this prototypic characteristic feature of microthrombocytopenia that is characteristic of the Wiskott-Aldrich syndrome. So to me, actually, this was one of the tricky questions of the reviewers. Now I know who the reviewer was. One of the tricky questions is really obviously ways, but they're not redundant, right? And they actually do exert different functions. And the phenotype of HEM1 deficient patients, as well as of the mice, is quite distinct from the Wiskott-Aldrich syndrome. Mm-hmm. We have actually also tried to sort of, have some sort of comparison of these two diseases, which was one of the questions of the actually critical reviewer for the paper. But I think it's a meaningful question because in some sort of way, we always take Wiskott-Adler syndrome as the prototypic actin polymerization defect. And then if you describe a new one, I do think that both clinically and also molecularly, one has to refer and compare to the Wiskott-Adler syndrome.
And of course, there is a lot of interest in this B-cell phenotype that is N1 patients have. And I think one, of course, it's a question on your single cell sequencing data where you have this cluster 1C. And the question from Klaus is this 1C cluster disease specific or just an outcome of the disturbed development of these cells? So it refers, I think, to this recently on low B cells, which they may be just this cluster, in fact.
Yes, very good, but rather tricky question, because I personally feel, and there's not going to be an easy way to prove this, it's going to be a combination of these two, right? So the simplified sort of summary model that we have is that because of the aberrant cell shape, the BCR signal doesn't occur at the spatiotemporal place where it should be, especially spatially. Therefore, B-cell receptor signaling is not as sort of strong as it should be. And that means that normally the B cell that should survive don't get sufficient stimulation to have survival, so they do go into apoptosis. And conversely, autoreactive B cells can actually survive instead of becoming a sort of anergic. So that's the simplified model. So I believe that it's actually a combination. It's a signaling defect during B cell development that means that you both have apoptosis of cells that should actually survive and also a differentiation problem.
Perfect. I would, Andrew, do you want to go on or shall I?
I think you're on a roll, Martha, so carry on.
Thank you. Italian, eh? Because I would move to, there are other questions to come, but I would like to ask a couple of questions to Anne. Beautiful talk, really, and you always manage to condensate really a whole story in 20 minutes, really, it's an art. And I think there is a lot of interest on your IL-6, SOGB130 and IL-6 receptor. Well, the first question is if patients, they have falsely low CRP during infection. I think this is important for the clinician, which may eventually see these patients.
So thank you, Martha. Thank you, everyone, for the question. So patients with IL-6 receptor or autoantibodies against IL-6, we didn't detect any CRP during the disease. So there is barely no CRP or no CRP increase. Mm-hmm. That was one of the main features. And the first patient with the autoantibody we found 12 years ago, nothing, no CRP at all.
Mm-hmm. And what do they use for infections, for example, procalcitonin, or what do they use as a correlate to help with the diagnosis of infection?
So they were procalcitonin, CRP, and then so they were also looking in vitro at IL-6 response. Yes.
Perfect. And I think that's another question. That's also something that I was also wondering myself. Why do they have hyper IgE? And also because, of course, tocilizumab patients, do they have IgE, but we don't actually see much of IgE increase. So the hyper IgE is still in mystery. So we were thinking, okay, might be IL-21, but then there is high IgE in the IL-6 receptor deficient patients. So I think we really have a lot of work to do here to understand the hyper IgE. So is it a cause or a consequence of the defect? We don't know yet, but it's still a mystery. It's still a mystery. So I don't have any good answer here.
Perhaps I could add a comment here that some years ago our group published a paper saying that bone marrow transplantation didn't work in STAT3 loss of function hyper IgE syndrome based on a couple of patients. I think we may be revising our views there, but one of the things that drove that comment was that after transplant, the IgE didn't shift very much. despite getting immunological changes from the immune reconstitution post-transplant. So that I suppose raised the question whether this is some kind of epiphenomenon driven by other cell types. I mean, we were completely puzzled and had no answer, but that was our question. But
we have a number of patients with skin disease unrelated to hyper-IgE, classical hyper-IgE, and who have high levels of IgE, not huge, but have high levels, and it might be also linked to some skin disorder for some of the patients, but it's still a mystery. Yes, we still have to understand what's going on there.
Indeed, always on the IgE, they said that the migraine deficient patients may also have high IgE level. Should that be considered a differential diagnosis in hyper-IgE syndrome?
Okay, yes, they have some patients have high IgE. I don't think we can consider them as IgE, so the classical IgE, but yes, there are many PID with high levels of IgE, which are not considered to be we are not entering within the IgE group, but there are plenty of other PID, and MYD88 deficient patients have also high IgE, but I wouldn't consider them as IgE, classical IgE syndromes.
Yeah, in fact, if I may comment on that, I think the field of class switch to IgE is now expanding, of course, and I think imbalances in intrinsic B cell signaling will actually drive the cells to IgE. So there is many ways to actually get an increased level of IgE. Now. So that's I think we will. You are totally right. We will learn a lot from that. I have a question also on your GP130, and because you didn't comment on the amount of plasma cells and the amount of antibody levels, because IL-6 is a very important signal for plasma cell survival. But you would expect them also in hypogamma, but it would be interesting to know that.
So you're right, but we didn't have such an hypogamma. So, but again, we will have to go deeper into that studies, I guess, because we still have a lot to learn about this. But we didn't see any strong defect.
So. Anything to comment, Andrew, or shall I go on? I have a couple of questions for Claire.
I think we've had nicely explored around the hyper-IgE thing, but I'd just like to say thank you, Anne. I think that was a wonderful overview talk, and I love the way you brought in the history at the beginning, because I think it's hard now, looking back, to realize just how little we knew and how confusing it was, and how well those early people did with the clinical descriptions and the scoring systems, which actually helped us delineate the clinical pictures. But now to see the whole thing open up, just incredible. So thank you. Yes, but Martha, do carry on as we think about the gene therapy.
Thank you. Exactly. There is a question from Andrea from the audience. There are tests on CGD gene editing, and if yes, which are details and the outcomes?
Okay, yeah, thank you. Yeah, the focus is still very much in the lentiviral field for CGD at the moment. So there's ongoing, there's been published results on trials for XGID and the P47 CGD, XNIT CGD, and the P47 CGD that we're going to be starting is using a lentiviral vector. There have been publications demonstrating editing technologies in CGD IPS and stem cells from groups in the US and Europe, but I'm not aware of any of those moving towards clinic at the moment.
Mm-hmm. And while I'm trying to read the other questions from the audience, I'm fascinated by your work, Claire, and I'm very much interested in bone marrow reconstitution, especially of the, BET cell compartment. So I actually never realized that for example, the ADA, gene corrected bone reconstitution is faster than a classical hematopoietic stem cell reconstitution. And why is that? Is that the conditioning? Because you can do reduced conditioning also in bone marrow transplantation. So do you have any hint on that?
No, so I mean, I think one thing is the amount of conditioning that we use is significantly less. So for those early trials and current ones, we're using a busulfan AUC of 20 or 25, so it's very low, and only gives us a really short period of neutropenia generally. I think we do see that there is a correlation to the number of cells that you infuse. So the higher number of cells that you infuse, often the quicker the reconstitution. So I think there's a function of that as well. But you're right. Overall, we generally see pretty good T cell numbers by 3 months post.
And I have another question on the what's the cause? So why the gene targeting correction is so low efficiency?
Such low efficiency. So I mean, there's definitely a number of factors that play into that. So one is the whole process of electroporating cells and then adding high quantities of AAV. That's just not great for the cells in general, so the viability can be affected. One of the other problems is dependent on where the gene of interest is expressed at the stem cell level and the chromatin landscape of those genes at the time. So, for example, things that aren't expressed at a stem cell level are quite tricky sometimes to then edit at the stem cell level without something like a chromatin opener to be able to allow accessibility of the gene editing reagents to do their job. So I think it's mostly those two things at the moment. But, we are seeing really, actually in the last couple of years, significant increases in the efficiency. I think that will become clinically relevant in the not too distant future.
And then just one question more I have, and that's, so how long is gene-corrected stem cells surviving? So how long will be this patient treated? So I don't know if we have enough follow-up now, but
yeah, I mean, good question. I think we've got evidence of excellent gene correction at the stem cell level. So for quite a lot of these patients, 6 months out, 12 months out, we will look at gene marking in the CD34 compartment, and it's we see good percentages of CD34 corrected cells across the different diseases, and that's borne out in the peripheral counts and the peripheral marking that we can see. The longest follow-up we have from the lentiviral studies is coming up to 10 years now, with stable gene marking in the context of ADA, and I wouldn't really expect that to be much different in the longer term. The patients who we have seen lose engraftment across some different diseases, that's generally been early. And so I sort of feel that if they've got to a year or 6 months or a year with stable gene marking, I really wouldn't necessarily expect that to change.
Okay, that's great. Thank you, Claire. There is another question for Cant here from Bodo on your DEP6. Should we also screen adults for variant in DEP6, or you think it's an exclusively autosomal recessive or early onset disease?
Yes, thank you, Bodo. I think this is a very important question. So we learned a lot during that study. And maybe one of the editors didn't quite understand the point, but I know the audience at ESID is very clever. So these two siblings that we studied in the initial family also had a non-identical clinical phenotype, which I think for us studying immune dysregulation may not be so surprising. They both had very severe disease. They both had very severe bowel disease, but the cardiomyopathy, for instance, was exclusive to patient 1, and the patient eventually died from that disease. Then we got in touch with Jan and Bryson in Sweden, as I said, and their patient was milder in terms of phenotype, although the cycling defect of CTLA4 was actually in our assays more severe. So whatever is compensating for that, I really cannot comment. And here the phenotype, as I depicted in my talk, was really a hematological autoimmune hemolytic anemia predominantly. What I'm trying to say with that is that I do imagine that probably similar to CTLA4, the phenotypes may vary both in terms of onset and in terms of severity and in terms of the specific type of immune dysregulation and autoimmunity that may occur. And so coming back to Bodo's question, I would absolutely think that you should screen adult patients with unexplained but severe autoimmune phenomena also for DEP6 deficiency.
There is another question on M1, and Denise asks, if you did see malignancy or autoimmune cytopenia as in STK4 deficiency in M1.
Yes. Good morning, Dennis. Nice to hear from you. We haven't seen malignancy yet, but again, this has been a very, in terms of numbers of patients and follow-up, a small cohort of 2 patients only. I would not be surprised if there's also cancer predisposition, but we have not yet seen malignancy in that disease.
Mm-hmm. And there are a little bit just more in diagnosis and screening of this ESID-2020 CD70 deficiency. Can you screen by fax? Do you need genetics? And where do you look at CD27? That's maybe relevant for the general audience.
Yes, excellent question. I think as for many of these monogenic diseases, obviously the types of mutations that one can have are very different, both in terms of severity, where exactly they're located, if they are nonsense or missense mutations, splice site, and so on. And that actually probably answers the question on the fax. So in our cohort, we had quite many patients who had deleterious nonsense mutations, and those ones then would lead to abrogation of protein expression, i.e. you could screen easily by fax. I do believe that the reverse is not true. So I think if you see CD27 on the surface, it does not at all mean that functionally you will have functional CD27 signaling, right? So it is a bit similar to some other gene defects where we have essentially a nice screening tool by a surface flow cytometry. But if you see the protein, it doesn't tell you it's intact. But if it's absent, it is quite, quite a clear sign that you may be on the track of finding CD27, CD70 deficiency.
Thank you. And I think there is actually a challenging question for Claire. What are the challenges to bring gene therapy to adults?
Thanks, Marta. That's a really good question. I'm glad it was addressed, actually. So obviously in the early days of gene therapy, the focus was very much on children and infants to access these technologies, partially on the basis of stem cell capacity, the idea that younger stem cells would react better, and also the concerns about thymic function preservation in SCID conditions. But as we've seen now, particularly with the lentiviral trials, adults have been successfully treated with gene therapy. So you will have heard Emma Morris talking at this meeting about transplants in adults with PID and how successful those can be. We're seeing similar things in gene therapy, and she's treated patients with Wisker-Aldrich syndrome and CGD, and we've treated older SCID patients as well with good immune reconstitution, suggesting that the stem cells are capable of keeping their capacity. And in the SCID patients, we have seen in the older ones we treated, like 11 and 13, sort of resolution of the TREX levels and things, so demonstration that again thymic function can be preserved. So yeah, we think we definitely have to include adults in the gene therapy debate.
Mm-hmm. Especially probably because you don't need, it's 10% of what you need in correction to
Yeah, I mean, that will differ between the diseases, but I think in principle now it's been demonstrated that adults can certainly benefit from this. And like I said a little bit in my talk, that the adults who have got comorbidities and just organ damage from years of recurrent infections, etc.
Exactly. Yeah.
I think they may be very good candidates.
Yeah. Any other comments, or do you see any questions? I think we have 2 minutes to go. So, Andrew, do you want to comment?
No, I think that's been a great discussion, and thank you for coordinating that so well. I just wanted to conclude really by saying thank you to our 3 speakers, and I think it was a wonderfully balanced program going across new areas of inborn errors. Wonderful to see the work described so well. I think the other thing that impresses me is how well people are describing things. Do you think we're doing talks better because we're doing them virtually? I don't know, but they're really great talks. And it was lovely to take us through from the basics of the biochemistry, the interactions, through to therapeutics. And this is what makes our field so exciting. And I think just looking back for me, because I first came to ESID in 1990, the acceleration of our knowledge and the importance of our knowledge, and just looking forward to where it may come from. I think my final throwaway comment, I just wanted to highlight about Cant's research interest, because for a long time, many of us have said that primary immune deficiencies are experiments of nature which teach us about the immune system and then will lead to ways to treat patients who don't just have primary immune deficiency. But often when we've been pressed and said, give us some examples, that's been a bit tricky. And I think it's very interesting with Cant's work to see just how this is expanding still further. I think, as I've already said, with Anne's work, it was wonderful just to see hyper IgE beautifully dissected and taken through to a new level. And with the whole question of gene therapy, gene correction and gene editing, where will we be in another 10 years, let alone another 30 years? And isn't it great that we can do so much more for our patients? I had to laugh yesterday hearing Steve Holland talking about doing bone marrow transplant for warts. Now, I'm being a little bit naughty there, but, how have our thoughts about curative therapies changed? We'd never have said that, even for severe warts, perhaps 5-10 years ago. So isn't it great we know so much more? And isn't it great that we can do so much more? And isn't it great that this has all come from the sort of collaboration, cooperation, and scientific stimulation we've seen from so many great people like our panelists in ESID? And on that note, I think we should draw this to a close and all go off to have a cup of coffee. Thank you all very much.
Thank you. Thank you.
Thank you.
Thank you, Claire.
Thank you.
Bye.
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 For listening to this